Hello, everybody. Good evening and welcome to BioMonde Live. Thank you very much for joining us. My name's Rebecca and I'm the UK Marketing and Customer Service Manager at BioMonde. But I'm delighted to be joined this evening by our expert guest speaker, Becky Sacree. So thank you very much, Becky, for joining us on BioMonde Live. And I'm really looking forward to hearing what you have to share with everybody tonight. So before we formally begin the webinar, I am just going to run through a few quick points with you all. So bear with me a moment just while I get these slides moving along. So the session tonight is expected to last around about half an hour, and we are going to set aside some time at the end just for any questions that you've got, either for myself and Vicky, the BioMonde team, or for our expert guest speaker, Becky. Now, the session tonight is all about the management of haematomas, particularly the management of haematomas in an acute setting, and how larval therapy can be used to improve that process. Now, if you're new to BioMonde Live and you haven't joined us before, I am just going to acquaint you with a couple of buttons that you're going to find useful as we go through the session. So the first is the chat button, and that is your space to network amongst yourselves. So don't worry, we can't see or hear you at home tonight. Your cameras and your microphones are turned off for the duration of the webinar, so you can only see and hear us, okay? And the second button you'll need to be aware of is the Q&A button. And that, if you just click on that at any time during the session tonight and just type your questions in, what we'll do, we'll then accumulate them all at the end and hopefully get around to answering as many as we can for you. And both of those buttons I mentioned, they can be found just at the bottom of your screen. If you just hover your mouse down, you should hopefully be able to find them. And you'll see some links on the screen as well for BioMonde social media. So if you are enjoying the webinar tonight, then do please pop up a post about it and do share that you're here. We'd really appreciate it. So as I said, we are joined by Becky Sacree tonight, and Becky is the Fundamentals of Care Senior Lead for Tissue Viability and Falls at the Hampshire Hospitals NHS Foundation Trust. And Becky is basically going to be teaching you this evening all about how to achieve effective haematoma wound management. She's going to be discussing the current practices at Hampshire Hospital, and she's also going to look at those that they previously adhered to as well. And around that, she's going to be discussing steps that were taken to implement and distribute the haematoma treatment pathway within the trust, and she'll be looking at the wider impact that that pathway actually had across the Hampshire Hospitals NHS Trust. And lastly, we'll be rounding off the webinar for you just with some patient case study examples, just to further enhance your learning and to provide some supporting evidence for you as well. So without further ado, I am going to hand you over to Becky, who's presenting.
So good evening, everybody, and thank you for joining me this evening. I'm delighted to be here to talk about the novel and highly effective approach to managing haematomas in an acute setting. Before I dive into the details of that, firstly, I'd like to thank UEFA for there not being a football match this evening and getting that out of the way. And secondly, I'd like to extend my heartfelt thanks to Vicky, Rebecca, and the rest of the team for giving me the opportunity to present to you this evening. I hope you enjoy. So firstly, my journey. It all began initially more than 18 years ago, working firstly as a housekeeping assistant in the NHS. I was maintaining a clean and safe working environment where I assisted patients with teas, coffees, and those all-important digestive biscuits. This role ignited my passion for healthcare and patient support, where in January 2006, I took the significant step forward and became a healthcare support worker. This role allowed me to work more closely with patients, providing direct care and support, and further deepening my commitment into the field of nursing. By March 2007, I'd progressed to the position of clinical nurse assistant. In this role, I was able to develop my clinical skills, gaining valuable experience working alongside the nurses and other healthcare professionals, and I was contributing more significantly to patient care. My dedication didn't stop there. It advancing my career led me to pursue further education. In September 2012, I proudly qualified with the Open University as a registered nurse. This achievement was a testament to my determination and hard work, and it opened the door to more specialised roles like I'm in today. In August 2016, I became a tissue viability clinical nurse specialist. This position allowed me to focus on critical area of patient care, ensuring that patients received the best possible treatment for wound management and skin integrity. Recognising the importance of leadership and management skills, I commenced an operational management apprenticeship in March 22, which I'm nearing completion. This opportunity equipped me with the skills needed to effectively manage and lead the team today. Each step of this journey has been an important building block for me, bringing me to where I am today. More recently, in March, I took the role of the Fundamentals of Care Senior Lead for Tissue Viability and Falls. In this capacity, I'm responsible for overseeing and managing and enhancing patient care, making sure that patients receive evidence-based care for skin and wound management. So I often encountered maggots, like many of you previously have, over the summer months, taking the rubbish out to the bins. To me then, they were simply just pests and rather an unpleasant part of summer life. However, my perception drastically changed when I joined the world of wound care. This was where I discovered the love for larval therapy. Often the same species we find in our bin, but they're incredible little creatures and tools for healing. Maggots or larvae therapy are great for several reasons. They're safe, effective, and clean the wound, removing dead or devitalized tissue, which promotes healing. The production process is absolutely fascinating. The larvae are bred in a sterile environment to ensure that they are free from contaminants. One of the interesting details is the production involving a specific denier of nylon tight, which I urge you to ask in the Q&A section later. What started as an unpleasant encounter during the summer months has completely transformed into profound appreciation for their benefits to patients. These tiny wonders, once seen as nuisances, are now recognised as valuable allies in wound care, showcasing the remarkable ways nature can contribute to medicine. This is why larval therapy, also known as maggot therapy, comes into play, as you can see here. The larvae are introduced to the wound and are remarkable for several reasons. They secrete enzymes, break down necrotic tissue, which then they ingest, effectively cleaning the wound. This process not only removes dead tissue, but also reduces the bacterial burden, promoting a healthy environment for healing. As many of you are aware, a haematoma is extravasation of blood outside the blood vessels, normally resulting to trauma. Haematomas can be particularly challenging to treat, as they often involve significant amounts of necrotic or dead tissue. It is particularly prevalent among the elderly and individuals on anticoagulants. If left untreated, it can lead to necrosis of the dermis or epidermis. Treatment options vary, including surgical intervention. However, this is invasive, it's a costly option, and requires the patient to be physically fit for surgery, which may also not be appropriate for those frail and elderly patients. If autolytic dressings are selected for wound debridement, the process can be gradual, potentially leading to ulceration from the wound and heightening the patient's susceptibility to infection. We in tissue viability are not often aware of these patients until after the wound has begun to ulcerate, or once the haematoma has been surgically evacuated by the orthopedic team, with the orthopedic team requesting tissue viability advice. Our organisation operates over 3 sites, including 800 beds. We serve a population of 600,000 people across Hampshire and West Berkshire. We're a dedicated tissue viability team of 5 nurses and 2 healthcare support workers offering a 6-day service. In the past, we've faced considerable challenges with treatment of haematomas. Prior to the implementation of our haematoma pathway, we'd received 12 referrals for haematomas. Of these cases, 9 required surgical debridement, where only 3 cases required tissue viability support post-debridement. The haematomas were also managed using autolytic dressings too. Surprisingly, most patients admitted with haematomas were automatically referred to orthopedics for that surgical debridement. The situation prompted an important question to us. Could those 9 patients have avoided surgery if a more effective pathway had been in place? This said question then led us to reevaluate and redesign our approach to the management of haematomas, and we aimed to develop a pathway. We had noticed some inconsistencies in the management of haematomas within the tissue viability team and wider trust. There were different approaches by various teams leading to unpredictable outcomes. There was delayed treatment, a lack of standardized pathway, often resulting in prolonged patient suffering and delayed healing. Ineffective use of resources due to the standardized practice. Inefficient communication channels with no structured protocol for timely intervention. There was inconsistencies with the referrals, the tissue viability team often not receiving a referral until after a surgical intervention had taken place. There was confusion among junior staff and patients due to the conflicting messages on wound management and who should manage that wound. The confusion led to extended bed days and unnecessary surgeries, resulting in prolonged recovery and increased length of stay. It was decided that a pathway should be created to assist both the staff on the wards, the emergency department, tissue viability team, to ensure that haematomas were managed in a safe and effective manner to enhance patient outcomes. By integrating the best practices, a more structured approach, and early intervention, we sought to enhance the efficiency, effectiveness, and treatment of our process. So why larval therapy for haematomas? It's safe, it's rapid, and it's effective. The larvae only consume the dead or devitalized tissue, making it a targeted approach while preserving healthy tissue, offering a safe and efficient alternative to surgery. As long as any bleeding is stopped and appropriate clotting factors are within therapeutic range, it's a viable option. It accelerates wound healing and prepares the wound bed further for interventions. These little helpers can help break down fibrin clots in as little as 96 hours, preparing the wound bed for subsequent therapies like negative wound pressure therapy or grafting. The therapy does not need to be seen by a specialist. It can be managed on a ward level. It can also be managed in the community as well, allowing patients to remain in their own homes, thereby enhancing overall patient satisfaction and reducing costs. To address the issues we'd previously encountered, we've created and implemented a new pathway. This pathway emphasizes early detection and intervention, and the use of autolytic dressings when appropriate, with a more rigorous assessment process to determine the best course of action for each patient. Every haematoma is currently directed to the tissue viability team for triage, where the referral inclusive of an attached photograph. This ensures the prompt initiation of treatment. Larval therapy is deemed appropriate and utilised where surgical intervention is deemed inappropriate. We have incorporated guidelines when larval therapy may not be appropriate, such as in cases involving clotting issues. This approach ensures tailored and safe treatment strategies for each patient, optimising outcomes and minimising potential complications. For wounds with a depth exceeding 2 centimeters, negative wound pressure therapy is applied, whereas shallower wounds, a polyabsorbent fiber pad containing the TLC NOSF technology is applied in accordance with NICE Medical Technologies guidance. This tailored approach ensures appropriate wound management based on the depth, maximizing therapeutic effectiveness and promoting optimal patient healing outcomes. We aim to transition patients to our specialised complex wound virtual ward. This transition may involve ongoing negative wound pressure therapy in the community, or it may be a more conservative dressing that the patient is discharged home with, depending on the patient need. Such initiatives have shown significant reductions in length of stay and heightened levels of patient satisfaction. Additionally, in cases where deemed suitable, a leg ulcer assessment may be completed to evaluate the potential application of compression therapy once the patient has been discharged. So the results of the pathway have been promising. We've seen a reduction in the number of patients requiring surgical intervention, and we've seen an increase in patient satisfaction from using a less invasive treatment. This obviously not only benefits the patients by reducing their recovery time and potential complication risks, but also helps optimize the use of resources and overall patient satisfaction. Wounds are now being debrided with larval therapy wherever possible. Tissue viability at successfully conducting timely assessments of haematomas, facilitating prompt and precise diagnosis. As I previously discussed, haematomas are now being managed by ward staff under the appropriate guidance from tissue viability, resulting in a heightened confidence and improved consistency of care. Additionally, significant cost savings have been observed due to reduced length of stay. Over time, care plans for this group of wounds have become notably more consistent and efficient, leading to enhanced wound bed preparation and ultimately improving patient outcomes. A standard operating procedure was created in conjunction to the new pathway, standardizing practice for all our clinicians. So let's dive into a case study. So upon admission, an 80-year-old female was admitted with a haematoma. She had the unfortunate event of a kitchen worktop falling on her leg. She was having her kitchen remodeled. So there's a 2-week history following the kitchen worktop falling on her leg. Initially, she received a 5-day course of oral antibiotics, which was prescribed by her GP. And she'd previously attended her minor injuries unit before being admitted to hospital. Her past medical history included IBS, hypertension, PMR, and reflux, so nothing significant. Initial blood tests were taken, as you can see there, platelets of 320. There was no active bleeding noted. So as you can see, the haematoma measures approximately 20 by 8 centimeters. The medical team had marked the limb for signs and further spread of any erythema. As you can see, there's some slight hard necrosis there with areas of superficial skin loss to the wound edge. No active bleeding. However, you can see in the photo that there is some pooling under that necrosis. So what are we going to do for this one? We opted for larval therapy. So before we were notified by one of our tissue viability wound care advocates who had highlighted us that this patient was on their ward, the medical staff had already straight away spoken to the orthopedic team at the other hospital site. So it would have been a 40-minute transfer to that other hospital site for surgical evacuation. For us, we quickly went up to the ward within minutes of being informed by one of the wound care advocates who highlighted she didn't feel that potentially surgical debridement was an option. So we went straight to the ward. Upon our assessment, my colleague and I opted to proceed with larval therapy as our chosen treatment approach. We provided the patient with an explanation of the treatment, and she expressed her willingness to proceed. She was delighted to learn that she would not have to be transferred to the other hospital and obviously have the surgery. We commenced treatment to prepare the outer layer for larval therapy the next day. This involved using a hydrogel and applying a soft silicone wound contact layer, along with a superabsorbent pad and type 2 support bandaging. Larval therapy was prescribed, ordered, and applied 24 hours later. And this is the photo here on day 0 of application of larval therapy. The next photo here is after 1 round of larval therapy. So the patient was absolutely delighted in the improvement in that short space of time, those 4 days, the dramatic impact that they'd had on cleaning up the wound. This is day 3 of therapy. We can see that it's showcasing granulation given the progress, and there's still that necrosis there, which we felt could be lifted, that we proceeded again with a further round of larval therapy. Patient was happy. This was subsequently ordered, prescribed, and applied again 24 hours later. Here is the photo on day 8 after the 2 rounds of 2 cycles of larval therapy. The majority of the haematoma has been successfully debrided. We initiated the patient on a antibacterial honey dressing with calcium alginate in anticipation for discharge into the community, because they felt that she was now medically fit with the improvement of the wound and it could actually be managed in the community, and the patient was then put on our complex wound virtual ward. Several weeks after discharge, our community colleagues completed a leg assessment and initiated compression therapy, and the wound has since healed. The patient expressed no pain whatsoever from the larval therapy, appreciated that there were different treatment options, and more so for not having to undergo surgery and the associated risks that came with it. Case study 2, this is a 32-year-old gentleman who presented with pain and swelling in his left leg. Past medical history, sadly, as you can see there. This gentleman initially reported pain in the limb, which had worsened over a period of 24 hours. The patient had previously been admitted to hospital 4 weeks prior, and he was diagnosed with having a DVT in that left calf, and he'd been started on enoxaparin. He was then admitted. On examination, the patient was pyrexic, there was erythema, and there was swelling to the left medial thigh with an increased area of swelling. I'm just going to add this photo. We unfortunately didn't have a photo on admission. This is the first photo that the tissue viability team obtained when we were when he was referred to us. We requested some imaging initially via a triage telephone call with the doctors for initial advice, and it was found that he had a large haematoma of the intramuscular compartment of the calf. He was therefore commenced on IV and oral antibiotics. After verbal discussion with the patient, being a young lad, we had extensive chats with him. We provided him with the information about larval therapy. He decided to proceed with it, and once again, we proceeded with the larval therapy. Following 4 days of larval therapy with a biobag 50, so 50 larval in the bag, the wound was successfully debrided 100%. There was some light bleeding observed, but at that stage it's quite normal. It was nothing to worry about. As the wound had yielded good results from the larval therapy, the patient had a maintenance pico dressing applied for 5 days. He was then discharged home and was discharged with conservative dressings. The feedback from this young gentleman was he was exceptionally happy with the healing time frame. When the larval therapy was first initiated, just over a week and a half, later, his wound was just requiring conservative dressing, which was supporting ongoing healing. And as you can see there, that's the photograph after having the pico for 5 days. And then he was discharged with the conservative dressings. So overall, it worked exceptionally well. And then the pico had finished off the healing. So the implementation of the pathway has significantly improved patient experiences and outcomes. Consistent, timely and well communicated care practices have led to high levels of patient satisfaction and trust from the patients with the clinicians. We ensure all patients receive the same high level care. There's swift and effective management of haematomas, reducing patient discomfort and promotes faster wound healing. And there was structured communication channels. This has improved clarity, reducing any patient anxieties. So in conclusion, haematomas are often treated consistently. Larval therapy offers a safe, rapid and effective option for debriding these wounds. By implementing a trust-wide pathway, we've enhanced patient satisfaction, care, empowered ward staff to manage these wounds, fostering enhanced confidence and skills. It's also resulted in improved consistency of care and generated significant cost savings. These savings encompassed reduced length of stay, avoidance of surgical procedures, and resource utilisation. It's minimised wound care resources, streamlined outpatient management, and mitigation of complications such as infections. We plan to audit the number of referrals we've received since the release of the haematoma pathway, and it will be interesting to look at the total cost savings since the implementation of this. Here are my references, and I've whizzed through that.
Oh, wonderful. Thank you, Becky. That was absolutely brilliant. I hope everybody enjoyed at home as well. I certainly did. So we are just going to move on now to the question and answer session. And at this point in the webinar, I am going to invite my colleague Vicky to join us. And Vicky is our clinical support manager at BioMonde, and she can answer any questions specifically in relation to larval therapy. So the first question that's come through is one for you, Becky. It's from Gemma, and she's saying that they are looking to potentially implement a haematoma pathway within their trust. She's wondering, did you get much support or pushback from your plastics team?
So we don't have a plastics team in our trust. We, for any plastics involvement, they go to a separate trust, so they're referred onwards. But we didn't have any pushback from orthopedic team or the general surgeons, which was really encouraging. And it's obviously lighting their caseload for them. So no, we've not had any concerns from any consultants or specialized departments, but yeah, I can't comment on the plastic side.
Okay, wonderful. Oh, thank you for answering that one. The second question that's come through from Megan, again, it's one for you, Becky. So she's asking, in your first case study that you shared, I think with the particularly large hematoma, did you use just one biobag at a time, or did you use multiple biobags to cover the entire wound at once?
So we used the largest bio bag on there, and then we were able to reposition the bag on each day when we were reapplying the moist gauze and reapplying the pseudocreme. So we were kind of able to put them where they needed to eat most, so to
Oh,
speak.
brilliant. Okay, thank you. The next question we've got through from Judith. Vicky, this is one for you.
Oh.
She's asking, can larval therapy be used underneath compression therapy?
Yes, they can. So they can tolerate up to 40 millimeters of mercury and 4-layer compression. So that's pretty much all systems, really. You can use under compression stockings, and I would say that's a really good time to trial a patient on stockings, because obviously if you're doing daily care, sometimes 4-layer compression is a lot to handle as well. But the only things I would be a little bit cautious about is like your wraps, so like your ferro wraps and things like that, because they are quite thick, and we've not trialed using them over larvae, and I wouldn't want to risk them suffocating. But yeah, most compression systems they're absolutely fine with.
Oh, fantastic. Thank you. And everybody, just so you know, if you have got questions for us tonight, you can just type those in using the Q&A button. So if you hover your mouse just down at the bottom of your screen, you'll find the Q&A button there. If you click that and just type in your question, it'll be on its way to us. So the next question is from Philippa. Thank you, Philippa. This could be one for both of you. I don't know who wants to jump in and answer this one. We'll find out. But Philippa is asking, can larvae be used on necrotic tissue if the haematoma is at that stage? Or does this need to be debrided before larvae can be started?
Good question. Well, shall I say what you would do, Becky, and then I'll see if it's different to what I would say.
I would initially soften it, so using like a hydrogel in the first 24 hours while you're awaiting the arrival of them to come. But they will certainly have a good old munch on that necrotic tissue. There won't be any concerns.
Yeah, that's pretty much what I was going to say. If you are competent to do so, you can score the necrosis and just do like a hashtag sign, and that's enough for them to get in. But not everyone's got sharp debride training, so if you can't do that, yeah, softening it for 24 hours is fine.
Lovely. Thank you both for answering that one. The next question we've got is from Jimmy, and he's asking, oh, Becky, are you able to share your trust hematoma pathway after the webinar? So,
absolutely. I was going to mention to everyone, if anyone would like a copy of it or even the presentation, I would be happy to share. And I think we agreed to go via Vicky, didn't we?
yeah,
Yeah,
definitely.
To be the distributor.
yeah.
Yeah, so if anybody does want a copy of either the slides or the pathway, if you email our clinical support at BioMonde email, we can certainly send
Yeah.
those out to you, okay? So I think, as far as I can see, I think that's it for the questions. I'm just going to double check that no more have come in the chat. Okay. No, so that's it for questions. So thank you very much, ladies. That was beautifully answered. Thank you to everybody at home as well for all of your questions tonight. If I can just find my slides, there we go. So a huge thank you to Becky. I think we're all in agreement. That was an absolutely wonderful webinar this evening. I certainly learned a lot, and I'm sure everybody watching did as well. So it was brilliant. Thank you very much. And if you have enjoyed the session tonight, we do host webinars regularly. You can join myself and Vicky on BioMonde Live every month. We host in-house webinars at BioMonde, and we do host obviously guest webinars such as this as well. So all of those can be found just by visiting our website, biomonde.com. And if you've enjoyed the session, we do have other learning resources available for larval therapy as well. So we've got BioMonde Now, which is our online video library. You can find that either on our website again or by visiting our YouTube channel. We've also got BioMonde Academy, which is our bite-sized e-learning modules. Really great for anybody new to larval therapy or those looking to enhance their learning. So again, you can find find that via our website. And lastly, we've got BioMonde Direct, which is one-to-one training, either virtually over Teams, or you can book an in-person session. And again, all of that's via our website. And if you are booking BioMonde Direct, you'll probably have a chat with Vicky, who, as I said, is our clinical support manager at BioMonde. And here are our details. So as I said, if you have got any questions after this evening, or there's anything you need from us, please do, of course, reach out. You can give us a call anytime. We've got our clinical helpline number there for you. If you'd rather, you can visit our website. There's a contact form available, and you can also send us an email as well, which is great for, if you've got any photographs and things like that. If you want to discuss patient cases or wound suitability, we will help you with everything like that, okay? And of course, we are on social media as well. So as I said, right back at the very start of the session, if you have enjoyed this evening, please do jump onto any of our social media channels and pop a post up and just let us know that you've enjoyed the webinar. We would really appreciate your feedback. And that is it, everybody. So thank you so much for joining us. And thank you to Becky as well. You've been a wonderful speaker. It's been fantastic. And to Vicky, thank you so much for helping out with those questions as well. So we will let you enjoy the rest of your evenings, but thank you very much, everybody.